So the first thing to say is thank you so much for holding this meeting today. It's really, really lovely to be back in person because we used to have meetings in person and then everything started to go online and then COVID happened. And it really makes a difference to be able to talk to people in the room. That's both the trustees, but patients, new members, new people coming for the first time. But obviously online is brilliant to have as a hybrid for those that can't come in the room. So we've got the best of both worlds. And that was a delicious lunch. So I hope you're not going to all fall asleep now, actually, it's only lunch. So I'm going to introduce all of us. So we have quite a big medical advisory board these days. I'm Jane Pritchard. I'm a neurologist here in London at Imperial College. And I've been on the MAB since about 2001. I'm studying a PhD in Guillain-Barré with Pritchard. And Rob, on the far left, is going to be speaking in a little bit. He is also a neurologist in London at King's College, also having done a PhD with Pritchard. And then more recently, Amy will introduce herself. Amy has flown down from Glasgow today to be with us today with a strong interest in purple nerve. You can introduce in a bit more detail. And Tim has come from Manchester on train, also with a consultant neurologist, and he ran from Euston to here this morning, and I saw a figure in shorts ahead of me and was shouting Tim, and he was on the ground. How is he? And Anna is back there on the table at the back, so a wave out from Anna, who has also come down from Glasgow. Okay, we've got other members of the MAB who are not able to be here today. We have Shakti Agrawal, who's a paediatric neurologist in Birmingham. Paediatric neurology is a much smaller specialty than adult neurology. So we're very lucky to have a paediatric neurologist within GAIN. Claire is a physiotherapist at King's College, although right now she's in Australia on a sort of 6-month sabbatical. Again, a specialist neurophysio, but has done a lot of research into Guillain-Barré and exercise, which is quite unusual. So neurophysios are also quite rare, particularly to have someone interested in Guillain-Barré and other inflammatory neuropathies. And we've got a new neuromuscular specialist now, Hadden Prescott, who works at the Walton Centre in Liverpool. So it's fabulous to have her along. And then we've got 2 more neurologists who are now both professors, Mike Lunn and Simon Rinaldi. And Mike is at Green Square and has been a member of the MAB for a long time. And Simon is in Oxford. And both of them do a lot of research into inflammatory neuropathies, but it's half term, so they couldn't be here today. So apologies, but they normally would have been, I'm sure. Okay, so what we thought we'd do, so you meet all of us a little bit, is we just do a few minutes each on each of the categories. So just talking a bit about GBS. I've put this up because zebras are rare, but they're quite characteristic. And Guillain-Barré is probably a little bit like that. It's rare. You will have all found that you didn't meet many people who'd had GBS, perhaps until you joined GAIN, or you made contact with GAIN, or until you were diagnosed with GBS. You probably had never heard of it. You probably never met anyone with it. We all get taught about it. Embarrassingly enough, at medical school, I think my nickname was the Queen of the Zebras, because I liked the rare stuff. So it's no surprise I ended up being interested in GBS. But you have to know what a zebra looks like in order to be able to recognise. And if you've never come across a zebra or heard of a zebra, you're not going to know that a zebra is a zebra. So, one gets taught about it at medical school. Now, some people, when they're on that brief neurology attachment that these days might only be 2 weeks in my trust, they might be lucky enough to have met a patient with GBS, but they might not. So, unsurprisingly, when people then go out and work in other jobs or become a GP, they may never have seen anyone with GBS. And because your average GP looks after about 1,000 patients, they might only ever meet one patient with GBS, and that might be you in their whole career. So if they get the diagnosis, they've done brilliantly. And if they don't get the diagnosis, they have not done disastrously, because it's hard to spot something you've never come across ever in your life. So we need to make sure people are aware of it, and it is definitely taught in medical school. But we need to try and increase awareness as much as we can. Rich mentioned there the A&E doctors. A&E doctors definitely have it as part of their curriculum. But the same thing happens. If they've never seen it, they might be taught about it in theory. That is so different from having seen it in practice. But we just have to keep plugging away, making sure as many people get exposed to GBS and other neuropathies as possible. And it's really difficult in the early stages. I'm sure a lot of you may have had the experience where perhaps initially people couldn't make sense of your symptoms, and it wasn't until it became really obvious that the diagnosis was made. And it can be difficult in the early days. So we've got some nice diagnostic criteria. And every few years or so, there's a new set of guidelines on how to diagnose it. But the most recent one, which was, I think, from last year, was joint between the European Academy of Neurology and the Peripheral Nerve Society. It's a lovely set of guidelines, which includes authors well known to this group, including Rob, Mike, and Hugh Willison, who was a member of the MAB for many, many years, but has recently retired within the last year, very much missed. But it's got really good guidance for everything about symptoms, diagnosis. But I thought the good practice points which were interesting that were highlighted was that GBS is definitely more likely if you've recently had an infection, particularly diarrhea of your chest or a chest infection. The absolute essential part of the diagnosis is that you have to have had clinical progression and weakness in your arms and legs for over less than 4 weeks, typically with reduced or absent reflexes. It's advisable to have nerve conductor studies to confirm the problems in the peripheral nerves, and lumbar puncture is useful. Classically, you have a raised protein, but not cell count. And a small minority of patients go on to have relapsing symptoms and subsequently get diagnosed with CIDP, which is a more chronic condition. Okay. And then there are some symptoms that clinically make us think GBS is more likely, including symmetry, sensory symptoms, but not necessarily very severe numbness, weakness of the face, altered pulse and blood pressure, which is autonomic symptoms, and respiratory muscle weakness. And often patients have pain at the start, which is due to the root inflammation. Going against GBS would be asymmetry, respiratory symptoms worse than the Lavin symptoms, any particularly dramatic sensory loss, and fever early on, or lateral bowel injuries. Now, I'm going to hand over to Amy, who's going to introduce herself and then talk about the current treatment in GBS, standard treatment, but also some of the new treatments and next thoughts.
Hi everyone, I'm Amy Davidson. I am a neurologist in Glasgow. And nice of Jane to have met Hugh Willison. So he was my mentor and worked under Hugh and did my research under him, and actually was involved in a clinical trial using a new drug in patients with Guillain-Barré. So that's why they've asked me to come and do a little bit about treatment talk today. So I'm going to talk about just now what do we do currently, and really what we do currently is what we've done for decades. There hasn't really been a big shift in the dial of what we've done since the 1980s, 1990s. So you guys will know because you've been through it. The most common treatment is this immunoglobulin. So it's a blood product that's from other people that we give to try and reduce the inflammation. And the alternative to that, which has kind of equal efficacy, is something called plasma exchange. And that's the blood washing where you get the cycles and we take your immune system out of your blood effectively and try and encourage the nerves to heal themselves over time. And I think that's the important point to know about the treatments. So at the moment, we can't heal your nerves. What we're trying to do with the treatments in Guillain-Barré is stop this inflammation, so stop inflammation damaging the nerves further. But once the nerves are damaged, what we're trying to do with the treatments is give them the best environment to recover themselves. So you can have this really fast catastrophic onset, as Jane was saying, within 4 weeks. But then people in this room who've had Guillain-Barré will know the offset is very different, and it takes a long time and usually a lot of rehabilitation and input to try and recover, because we can't do anything to help with the nerves as it stands. And then that's just thinking about how we're treating inflammation of the nerves as well. But I think it's important to bear in mind when we're thinking about treating patients with Guillain-Barré, yes, we want to treat this inflammation in the nerves, but there's other things happening with the patient alongside this inflammation in the nerves. We can, inflammation in the nerves cause a lot of pain, so we have to think about that, really seriously from the start. We have to think about if there's changes in blood pressure and the pulse, how we're treating that and where we're treating these patients, in medical wards. versus, versus higher dependency wards and these kind of considerations when we're thinking treatments. And then we also need to think about who are patients once we're given these treatments who aren't doing well. Why are you not doing well? Is there something different about your Guillain-Barré syndrome compared to the kind of more typical Guillain-Barré's? And I think we're learning more about that field as well. So Sam Rinaldi sits on the board is looking to slightly different inflammatory neuropathies that can look like GBS that affect something called the paranode. And don't worry, we're not going to take you to too much science, but can we start identifying these patients? And can we influence treatment at that point? So lots of different things that I think we need to be thinking about. But as I said, I'll move on. This is, don't worry, a very busy slide, and I'm not going to go into too much detail, but we've got the current treatments. And really, you can see it's a list. And what we're really trying to do with the treatments just now is we think that a lot of Guillain-Barré, or certainly the one that we recognise the mechanism, is quite often there can be antibodies involved, so part of the immune system. And so we are either trying to get rid of that with immunoglobulins or plasma exchange just now. But what I wanted to illustrate is there's other things going on in the immune system. So we've got other targets. And so the drug trial, unfortunately, that I was involved in, and a Japanese group also did a similar drug trial, was looking at a different part of the immune system called the complement cascade, and that was using a C5 inhibitor, and neither trial had a positive outcome. But that's not to be disheartening, because we're still interested in that part of the immune system. And I'll go and talk about that a little bit in a minute, because if you go further up, if you intervene earlier in that cascade, it looks like actually you might be able to have a positive effect. And then we're looking at other drugs. Can we affect other parts of the nervous system? And is that going to have, can we stop this inflammation? And all of these kind of on the top above the pink are all thinking about trying to stop the inflammation in the nerves as a target. What we haven't got to yet, and what I think is a big area of interest throughout all kind of degenerative neurological disorders, is there any way that we can protect the nerves? And that's starting to come more to the forefront as well. So, when we are taking down this inflammation, can we protect the nerve, or can we repair the nerves in any way? So just to give you a kind of indication that things are ongoing. And what's that look like kind of clinically? Well, there are ongoing trials, some in their earlier phases than others. So efgartigimod, I don't know, we'll talk about that more in CIDP a little bit later. But that is a treatment that we use in other screen. Is it interesting in Guillain-Barré? So that again works on antibodies, trying to kind of cleave down and stop this kind of antibody response. So that's in a trial that's ongoing just now. And then there's a new treatment. So I talked about this complement, don't worry too much about it, it's just part of the immune system. But we realised if you go in slightly higher up at an earlier level, it looked like they had good evidence that we can, it was a more effective treatment for Guillain-Barré. And they've actually just completed a new trial, and it's had a positive result in its phase 3. So I'll show you again, lots of information here. But the take home is it was a trial that was mainly conducted in Bangladesh and the Philippines, and sometimes they have GBS that clinically is a bit different. But when they looked at the subsets, you still saw the subset that we saw here, so it looks like there could be efficacy. But the other thing to notice here is that we have treatments in the UK, so we can give you immunoglobulins and we can give you plasma exchange. In countries like Bangladesh and the Philippines, you don't always have access to treatment. So this was against placebo rather than our best practice. So I don't know if we're going to see this the same level of improvements that you see. But that's not to, and this is all kind of unpublished stuff, so it has to all go through peer review. This was things that were being presented at conference, but this is brilliant. We have moved the needle. We've actually found positive, a new drug that's going to do something in patients with Guillain-Barré. So, I've been a bit of a Debbie Downer there about it, but I don't think, we're all delighted that we've seen something, and there's a very good forward and exciting impact here. And then really, so don't worry about this. This was just when we're starting to think about kind of more neuroprotective things. I was saying nobody's having any thoughts about that. That's not quite true. There are some things, and then we realise there's other parts of the nervous system beyond just tackling this inflammation in the immune system. We go further into the nerves. We're starting to have a greater understanding that there's areas that we can maybe target that are going to be neuroprotective, but we can get involved in at this point, very early stages. That this is animal model stuff, but I want to just think of the whole spectrum of things that might be commented and available. And it was really what I was going to say about don't worry about that. We don't need to get to mouse modeling at this stage in the game. But effectively, we have treatments that we know are effective in inflammation. And we've got good treatments, and we are very lucky in the UK to have access to them. But we are actually now, with our greater understanding of what's happening in Guillain-Barré, beginning to move the needle and having an idea of other targets and things that we can move forward, it's really great. And I just want to kind of reinforce that we're in actually quite a positive and moving forward time when it comes to GBS and GBS treatments. There's other ongoing trials as well, and there's things that we're looking at. So, watch this space. So next time I come and speak to you, I might have big words. I'm going to pass on to Tim, because now we're going to switch from GBS to CIDP.
Hello everyone, and I'm not going to tell anyone my nickname from medical school, Jane. Getting started. So I'm Lavin, a neurologist in Manchester. I've been interested in coronary disease as well. So I'm going to just briefly talk about background of CIDP and chronic inflammatory demyelinating polyradicular neuropathy. Bit of a mouthful to say, but just to kind of summarize, I think people think about it as the chronic version of GBS, and whilst there are some truths to that, there's also quite often it's obviously very different. First of all is the time course. So this is a condition which will progress over 8 weeks. That can be a rapid progression over 8 weeks, to the point where people are very disabled. Well, that could be considerably slower in some cases where it could come on slowly over a few more years. What we are talking about, what is similar to GBS, is aggressive, largely symmetrical weakness, which is proximal. We're talking about proximal around the shoulder, around the here, and also some distal weakness, affecting hands, affecting feet, causing for a stroke to alter. So in addition to that, it is a motor and what we call sensory process, and with sensory modalities and perceptual analysis which are involved. And actually, interestingly about this, again, we talked about how if you have very profound sensory loss of presentation, it can be a little bit atypical of GBS. And because largely what we're talking about here is in terms of the sensory loss that we lose, is this what we call joint vicious sense. So my left arm is up here, my finger's pointing downwards. I'm aware of that not because I'm looking at it, because of the sensory information which is coming out and tells me it's moved up. So those people who are sat in a bed being examined by a neurologist may have that slightly weird thing where we're moving your toe up and down and asking this up or down, and that essentially is what we are testing. And that is what we call a large spinal component to neuropathy. It's an essential we see in CIDP. It can lead often, sometimes I find to misdiagnosis early doors. People walk funny, and everyone thinks they're a bit mad. But they're not mad. What they've got is they've got a lack of sensation in their feet. Okay, and that is leading them to get more balance when they're walking. They can have a funny walk. On the bed, people might miss out on examinations. They're not an expert in the condition. According to the education talk track. Again, similar to that, we also have the concept of reduced or absent reflexes, tendon reflexes to suggest it's a nerve problem, not a brain problem. And these are key to the typical CIDP diagnosis. Now, nerve conduction studies are important. So we talked about how in GBS, you can largely make that diagnosis quite clinically, quite early, on the basis of the CSF analysis. In CIDP, nerve conduction studies are a much more important part of your diagnostic criteria. And we often see what we call slowing of conduction. So it's a slow impulse down because the myelin sheath is the wire to the kettle. When you lose the conduction around a wire, you will have slower conduction along that wire. So what we've got here is the myelin sheath, which is affected, getting slower conduction down that nerve. So there are important things to think about the CIDP. So it has mimics, and some quite important mimics. And Amy's touched upon this already. So this evolving group of disorders that we term the autoimmune neuropathies. And what they demonstrate is a lack of IVIG response. So these patients will have no IVIG response. They can progressively get worse, but you can't use rituximab in those conditions with good effect. It's a different medication. It's a biological treatment used in things like rheumatoid arthritis and many conditions. They can have a good effect, basically permanent or remission. So they need to support people aware of them, but that increasingly they are checked in patients who present what appears to be typical CIDP. There's a long list here, I won't go through everything, but important things which are associated with hematological disorders, especially forms of called paraproteinemic states, where people have an excess of a certain component of your immune system. They can be elevated, and they can lead to a variety of different neuropathies which look very similar to CIDP. So again, they should be investigated for a diagnosis and then treated in a very different way. Increasingly, we are finding lots of genetic disorders. Well, traditionally, when you think about genetic disorder, you think about someone who's a child in their 20s, their 30s, they've got polyneuropathy, and it's quite evident that condition is there. But increasingly, I'm sure everyone in this audit will found that with the widening of access to genetic testing, we're increasingly finding patients who have been diagnosed with CIDP for a number of years, and they actually carry a genetic mutation called Guillain-Barré disease, which is a genetic inherited disorder. So increasingly, that's forming part of our investigation of patients who appear to have CIDP. And certainly something which is treatment resistant or it is slower, longer onset, irrespective of age. Moving down, there are variants of CIDP. So we touched on the typical CIDP there, symmetrical, affecting shoulders, hips, all the way through, very weak, wobbly bowels. Whereas we have patients who may just present with distal weakness, just from the neuritis. Patients who present with multifocal CIDP, so it's quite asymmetrical. They just affect the left upper limb, right upper limb. It may affect focal one limb, just on one side. It may affect maybe, if it's motor only, there is a variant condition called multifocal motor neuropathy, which is slightly different, but is still IVLG responsible, but it's important to recognize. But also, and there are some sensory variants as well. Again, care needs to be taken about diagnosis. It's a tricky one to make. But we have these increasing variants and mimics of CIDP, which you should be aware of when we're making our nexus. Big one. Yeah. So in terms of treatment for CIDP, again, there are some common aspects to Guillain-Barré syndrome, which is some important differences. So the first line treatment is IVLG, which I already mentioned, which is it has a good response rate in about 70 to 80% of patients. 70% of patients will have a good response to IVLG, first line treatment. But steroids can be also very effective. In some patients can good response rate is about 60% of patients as well. So that differs from GBS. Steroids are a good treatment option in CIDP. But it's important because patients can go into remission spontaneously with their CIDP. It's very important that patients have trials of when we take that treatment away to see if they still have activities. If they do not have activities, we're giving them a treatment potentially side effects, which is actually causing nothing but potential harm from giving patients any benefit in terms of their walking or their balance. So patients may have gone through that, so even disorders may have gone through that process. I appreciate it's difficult, but at the moment it's some important thing to do until we get better ways of monitoring the disease than simply just neuropathic remission. So can the IVLG subcutaneously in CIDP? That's been proven. So you might better expand on treating kidneys. Now, it must be down.
Sorry.
And how available that is an option. Now, let's previous slide to show me.
Yep.
Okay, sorry. Thanks. So, again, I've talked about steroids already, and plasma exchange is an important one to touch upon again. So, we talked about plasma exchange having good evidence in GBS, as good evidence in CIDP as well. The problem is this is a chronic disorder that will involve plasma exchange longer term to try and maintain people in remission. So we would tend, given the difficulty of administration, the everything's required around plasma exchange, to not choose it first line. But it is an option for some patients if you have everything in place in your local unit to do it in a safe and appropriate manner. Now, again, if those don't work, those established treatments, going back to the mimics and going to what we just talked about, you really have to rethink the diagnosis. The misdiagnosis of CIDP is actually quite common, and that's largely because of the histological tests, which can look very typical, but there are other conditions which can look like CIDP, which always important on our mind. So, again, that is standard treatment at the minute, but I'll just pass on to Rob, because Rob will now go through what the potential futures can look like in terms of the treatment of CIDP. Thank you.
Hi, I'm Rob Hadden. I'm a neurologist at King's College Hospital, London, and also on the GAIN Medical Advisory Board. So it's great to meet so many of you here. And if we could have the next slide, please. I'm going to talk a bit about research, particularly in CIDP. And we're grateful to GAIN Charity for having contributed money towards paying for some new international guidelines for both GBS and CIDP. And I was on the group of international experts who were writing these guidelines. One of the issues with the research is there's so much of it. there are thousands and thousands of medical papers published every year, and general doctors can't be expected to have time to read them all. So a really important part of the process is producing evidence-based guidelines. That means that the guideline team of experts looks at all the published medical academic papers and combines them into a short group, a short list of recommendations which are practical and aimed at general doctors to be able to diagnose and to treat these diseases. And so thank you to Gain Charity for helping to fund these guidelines, which have been recently published and hopefully have made raised awareness amongst doctors and neurologists about best practice. New things then. InkBase is a registry. So this is a form of collaborative research. And we're just getting started in the UK, but this is part of an international group. And essentially, we want to try and enroll individual patients who are suffering from CIDP. And we're going to gather data about individual people. And when we've got large numbers of patients in our database, then we can do research and look at the differences and the similarities and try and draw conclusions about why some people do better than others. So we hope that as many people as possible suffering from CIDP will consent to have their details entered into this database, and if so, speak to your neurologist. Then there's some new medical drug treatments on the horizon, which are looking exciting. And having had not many new treatments for years, actually, we somehow now seem to have several coming along at the same time. And I should say, though, that these treatments are work in progress. The things I'm about to mention have been studied in an initial phase randomized clinical trial. They are not yet published in a medical journal, they're not yet peer-reviewed, and they're not yet available on the NHS. But this is very promising work in progress, which is giving good initial results, and will need a bit more research, and it's going to be a few more years until it's actually available for real people, but it's exciting stuff. So the first one to mention is efgartigimod, which is, it works a bit like plasma exchange, but actually you have it by a little injection once a week, I think. Technically, it's called an FcRn blocker. And this treatment really seems to work in CIDP. But what we're not quite sure is whether it is better or less good than some of the existing treatments. My personal view is it's probably not quite as good as IVIG, but it may well be a useful treatment for people who aren't doing so well on IVIG. And it certainly has an effect, and we need further work to see where it fits in with which patients are going to benefit from it. And then there's a new category of treatment called complement inhibitors. And I think that these are even more exciting. If I could have the next trial, please, the next slide. Complement is a part of the immune system. And in simple terms, what it does is when the immune system produces antibodies, then the complement is the mechanism of how the antibodies actually damage the cells. It's how the antibodies damage the nerves. And so if you have a drug that blocks complement, it's not getting rid of the antibodies, but it is preventing the antibodies from doing damage to the nerves. And actually, there's several different drugs that are targeting slightly different bits of complement, but there are 3 new ones which seem to have worked really well. Amy mentioned a few minutes ago in Guillain-Barré syndrome, how a complement blocking drug seems to have had a really good effect in helping GBS if patients have 1 dose of it right at the beginning of their GBS. But We don't quite know how much better or less good it is than IVIG, and we need more work into it, but it's looking really promising. So now this is CIDP, and this new drug, really Pritchard, has been tested in CIDP. And if I could just see if my pointer is working, which is the pointer button. There's no pointer. Okay, so this has been tested firstly in patients with CIDP who are already on IVIG or steroids, where they've had some benefit, they've already got a bit better from those drugs, but perhaps they're not as good as they'd like to be. Then what happened in the trial is they stopped those treatments and then they immediately started the new treatment. And so if you look here at this bit, it shows that of those patients, half of them got a bit better. So they thought they were already improving with the IVIG or the steroids. They went on to the new treatment and half of them got even better. Now, I should caution you that there was no placebo comparison group. So it may be that some of this is a placebo effect, that people think they're getting better just because they're getting a fancy new treatment, and we need to move on to placebo randomized control trials to be a bit more certain as to whether it works or not, but it's looking really promising. The second group of patients is this one in the middle. So they had tried IVIG or steroids and they not got better, or only got a little bit better and not very well. So when they then moved on to this new treatment, half of them improved. So that's really promising because it shows that patients who hadn't responded to our normal best treatments, half of them did get better. And then the third group here is patients who'd not tried any treatment at all before, and 3/4 of them got better when they tried this new treatment. So it looks to me as if this new drug probably works better than IVIG or steroids, and probably works better than efgartigimod in the previous slide. And then when people stayed on it for a year, of the people who got better, most of them stayed better. So it continued to work. And the treatment, I think, is given as an injection once a week. It's a straightforward thing that people ought to be able to give themselves at home. It's one of the problems with CIDP is that some patients over a period of years develop secondary axonal degeneration. The muscles become thin and wasted, and there is permanent axonal damage to some of the nerve axons, which then means they're not going to respond to any immune treatments. And one of the promising things with this one is that when they measured something called neurofilament light in the blood, that got a lot better with this treatment, which probably suggests that this treatment is helping to prevent axonal degeneration as well. And certainly, I think it's really important that we have more treatment in future, more research in future, looking at axonal degeneration in GBS too. And Amy mentioned that with calpain inhibitors, and there needs to be more research done into that. So next slide, please. So I'm now going to talk about a different disease, MMN, multifocal motor neuropathy, which is a bit like CIDP, but it's a different disease and even rarer. So currently, there is only one treatment for MMN, which is intravenous immunoglobulin. And if that doesn't work, then you're stuffed because there's nothing else that we know that works. Until this thing has come along. So empasiprubart is a different form of complement inhibitor. And I'm going to talk you through a trial that seems to show that that works quite promisingly. So in these patients were already on IVIG treatment, and they had to stop that and then immediately start either the new treatment or a placebo. Next slide, please. So this shows that patients who were on the new treatment mostly stayed good, but patients who were on placebo mostly got worse. And so this the gap between these two lines here shows that there is a big benefit from the new treatment. However, there were quite a few patients who got more better. So they'd already been on IVIG treatment, and they thought they were doing reasonably well with that. But when they started a new treatment, then quite a lot of them got even better in terms of the strength in their hands and disability measured on the disability scale. So that's very promising. And indeed, speaking to the chief investigator in the Netherlands who organized all this, he says that quite a lot of his patients said that this was the best they've been for years. Next slide, please. This, however, was quite a small trial. There were only about 30 patients in total having this. This promising initial result needs to be repeated, and there is going to be a larger clinical trial going to take place to test this more thoroughly before it can come to being clinically available. But it looks really promising. I mean, of course, one of the downsides of these new treatments is that they're going to be expensive, because it's really expensive to run these international clinical trials, and IVIG is expensive, and these new drugs are probably going to be even more expensive. But if they work well enough, then the NHS ought to fund them. Fingers crossed. Thank you.
Well, you've well and truly destroyed my time. But I'm not going to interrupt, because there's a huge amount of information there. And I can see lots of people nodding away when their condition came up. And going, yeah, and loads of us, loads of guys. We've got a very in tune team. We are over, but we can put it back. It's fine. We're going to put it back. You've got time to go in. It's all good. Can we, if anyone's got a couple of quick questions, well, you've got these guys here. I mean, they're going to be around, so you can get them later, and you know who they are now. You can literally go and grab them. Don't do that. You go and talk to them. But has anyone got a question? Slides down for an slides. Are we allowed to share the slide? I see like raised eyebrows. I'm not sure.
Yeah, it's okay. It's in public space. So some of the pictures from my trials were photographs I took of presentations and conferences. So yes, you can share the slides.
Yes, brilliant. Yes, we have. There we go. Anyone else got a question? No questions at the minute. Do remember that we've got a question and answer panel later. So if you do think of anything, you can hold it up there. Jane's going to join us for that, and the others will be in the room as well. So you can do that. So can I just say, we say a massive round of applause to the incredible name on the store.